Folks, as I mentioned this morning, my name is Jim Guthrie. I'm one of the consultants with the Continuing Care Branch of the Department of Health and Wellness, and I've been asked to help to facilitate or guide this particular part of today's forum. These are basically short presentations. There will be 10 minutes each. And from District 4, we have Tracy Martin from the Colchester East Hands Health Authority, Diversity Initiative, and Aboriginal Health. Clara Coward from Mental Health Initiative with our African Nova Scotia community. Dr. Barb O'Neill and Barb Campbell from Primary Health in the Mennonite community. And from District 6, Promising Practices from a Diversity Lens, Charlene Thomas, Director of Mental Health and Primary Healthcare. From District 7, GASHA, Health Equity Highlights. We have actually a video on health equity, which is an overview from GASHA. An memorandum of understanding with First Nations on providing services. Julia Gillian, Health Director, and please forgive me, Julian, Julie, if I get this incorrect. I think it's called Pak Niktuk, First Nation. Buttontuck. Well, it's something like that, I guess. I'm trying to get it, and I do apologize for that. And Julia Gillian is also, I believe, a parish health nurse. Is that correct? No? Pardon? Okay, Mary Desmond is the parish health nurse. That wasn't here, I'm sorry. And Sheila Sears, the Director of Public Health and Primary Health Care. And Mary Desmond is also a parish health nurse as well, too. Okay, folks? And maybe we can start with you.
Yeah.
Perfect.
Sure, sounds good. Okay. Hi, hi over there. I'm Tracy Martin, and I'm with the program lead for primary health care with Colchester East Hands Health Authority. We are a really informal, unplugged group. Actually, we were just meeting for the first time prior to this session. Not the first time, we all know each other, but to prepare for this session just before we came in the room. So bear with us. We kind of like to take the approach of share stories and quick stories because I've told my colleagues here, we each have 3.33 minutes. So we have to be aware of that. I also want a quick apology to Sharon because I know I scared the heck out of her because she was like, oh my God, they're not showing up because we were here very late, but it was a little fun on my part. Sorry, Sharon, but it was good. So as part of the portfolio that I have for primary health care, diversity and social inclusion falls under the work that I do. So kind of an overarching strategy and initiative and diversity is something that we've been working on. We have a very unique situation in where our board and our senior leadership team are extremely interested and passionate about this. They really think this is something that we should be doing as an organization. It's something that should be embedded in everything that we do. And we've had a lot of great support to move things forward. About 2 years ago, we actually developed a diversity strategy, which included an orientation module on creating cultural comfort and safety in our organization. And we're just getting ready to train some lay leaders. And really the premise of the work that we're doing, kind of the philosophy of that is kind of meeting people where they're at. So it's not just about specifically race, gender, those types of things, because people immediately go there when we say diversity and social inclusion, but it can mean very broad across the spectrum and coming to meet their people in the world, the reality that they're living today. So I didn't do fancy slides, and this is probably hard to see, but this is our visual that's associated with that. So you see it's a raindrop on a leaf with the world in there, so representing what each individual's worldview is. And this is the kind of branding that we're using with all of our diversity stuff as we go through the organization. So another piece, a specific piece of work that I'm involved in, oh, good Lord, didn't mean to do that, is the work that we're doing with our Aboriginal populations in our district. We actually have the largest mainland population of Mi'kmaq in our district with Indian Brook and Millbrook. And over my time at the district, we've been building our relationships with those communities. It really started off with our mental health clinic going in, diabetes clinic going in, those types of things, and providing some satellite services, a little bit kind of ad hoc, and learning to provide those services in a way that was going to work for those communities. probably about 4 years ago, we were fortunate enough to get a grant through the Aboriginal Health Transition Fund that was for us to work with our First Nations communities on mental health issues. That's what they wanted to focus on. But we very quickly got into some difficult conversations about, every time they meet with the district, they want some resources. They're like, why can't you help us? Why can't you give us some more resources, more bodies in the community? And what it did, though, it was enable us to have some conversations about what each of our realities were and why maybe it wasn't so much about just plugging more bodies in there, and maybe it was about how we provide our services and how they understand how we work and how they work as well. And we had some really great conversations around, okay, I get it now as a district, that's why that you can't do that this way, and we're very fortunate to maintain those relationships. And as a result of that, we actually developed a book, and I've brought a few copies, and I'll put them on one of the back tables, called The Feather Effect. And it talks about building cultural bridges. And so Indian Brook, Millbrook, the district, and the consultant that we work with developed this book, and I encourage you all to read it. And we can actually send more copies to you. There's some access to it online as well. And we actually just had a request recently from the Breast Cancer Coalition of Nova Scotia that this pretty module that we have developed, they've asked if they can take it and adapt it so that they can use it as part of their training for providing breast screening services in First Nations populations. So we're pretty proud of that. And we're really proud that just in the last couple of months, we were extremely blessed. This is going to be a project I'm so excited to work on, because it's one of those things that, you work in the district, you work in government, and you're kind of chugging along and you're doing what you have to do and dealing with the realities you have to deal with. And very often do you get something that you can go into and go, this is the right thing. We're finally doing the right thing about something. We have been approved for a physician and a nurse practitioner primary care collaborative team in Indian Brook. So we are working, thank you. It was a very collaborative process. We developed the proposal together with the community. And we go to chief and council and report, and we're just in the process now. So if you know any fabulous physicians, please send them our way, of recruiting for the physician. And again, very much involved, regular meetings. They actually are thrilled to bits to go on electronic patient record. We're getting ready to put them on My Nightingale in the clinic. So we're very excited about that. And some people say, well, how do you do this? Like, how do you get through this? And what are your secrets? Like, there's really no secrets to this. And it's kind of interesting moments, and you'll see that in this book. It's kind of the weirdest moments you think that are going to be the ones that come forward and build that cultural bridge for you. The last meeting I was just at in Indian Brook, we were sitting at the table, and there was actually some new people from the clinic at the table that I hadn't met before, and they were kind of looking at me and trying to size me up, and what is she really doing here? Is she giving us something? Does she need something from us or whatever? And so they were talking about different things. There was a little sidebar conversation down the end of the table. And there's this thing about women in Indian Brook, and I tell them this, I write directly to them, is that they love to store their cell phones right in here, right? So they ring and they pull these cell phones out from their bras in the middle of meetings and start talking. So somebody did that, and the girl next to her said, "Ain't nobody got time for that," which is a line from a very funny YouTube video. And I was like, oh my goodness, I love Sweet Brown. And they were like, you know Sweet Brown? And that was it. Like, we're now best friends. We're sending emails to each other, and we're bonding. So it's not always about going in there with a physician or a nurse practitioner or knowing the culture in and out. It's maybe a YouTube video that's going to help bond you and have a good relationship with your community. So I'm now going to hand it over to Clara, who's going to speak to the other components of our diversity initiative. Thank you.
So my name is Clara Coward, and I work at Colchester Hospital, and I'm a social worker, and I've been working there since 2007, working on a child, adolescent, and family team. Can everyone hear me? So how the diversity committee formed was that we were looking around, me and the other clinician, and we were thinking, okay, there's not a lot of African Nova Scotians that access our service. So what can we do about that? So we called our manager and other clinicians, and we kind of formed a small committee at that time. And we were just kind of brainstorming to think, okay, how can we offer our services? So then we went to the school, and we partnership with the church and the local police, and we started to just kind of network and kind of build relationships. And after we started to build a relationship with the church, we attended some church services, and we had some some guest speakers come in to talk to staff around just cultural diversity within mental health first. And then we partner with the school. And me and another clinician started to work with the schools, and we're currently working with 3 schools, so the elementary, the junior high, and the high school. And this has been ongoing for the last 2.5 years that we've been in the schools. And it's just been an amazing project in terms of just building those gaps. And so currently what we are doing, we are at a process now of having a parenting workshop at the end of this month for 4 weeks. And for the high school level, we partnered with, it's more like a mentorship program, and we're offering almost like a big buddy or mentorship program for youth between the ages of 18, it was probably 13 to 18. So the project is ongoing. It's something that we are quite passionate about. We do have our hiccups sometimes, but overall, it's been very high success in terms of just building relationships and encouraging people to access our service. Thanks.
Hi, I'm Dr. O'Neill, and I work in, my practice is in Knoll, and Barb Campbell is a nurse that works out of my clinic as well as Kennecook and Rawdon. And so we work a lot with the Mennonite community, which is located close to our office in Knoll. Maybe there's about 300, 350 people living there who are of Mennonite faith. And I guess for us, the main things that we've learned over the past 7 or 8 years working with that community is that some of the barriers that we have to work through would be language, because they speak a low German dialect as their first language, but most of them do speak English. But also some of their cultural and religious beliefs that would affect things such as preventative care, which they're not uniform in their beliefs, but for the most part, we have to adjust our expectations as to well baby care or preventing heart disease, that sort of thing, prescribing cholesterol medication that's just not would require a much longer conversation and dialogue than your average patient, and also. I think some of the things that we've done just naturally to become more accepted in the community is we do house calls there. I've been to some weddings, funerals. We've been working basically naturally forming ties, I guess, with the community over that time period. I'll let Barb mention. With working mostly with children, I guess, when you...
Yeah, I do a lot of the well baby visits, and often they'll come for their first visits when they're with their newborns. They'll come to see us, and you really have to capture them when they come, because we may not see them again for 6, 8, 10 months. Unless their babies are really sick, often we won't see them. So when they call and say, I have a sick child, you know that they really do have a sick child, because they've tried everything else at home, and now they really need to be seen by the physician or the nurse. And so it's just being open to them and realizing when they do call, they do need to be seen right away. But there's also, we can't just assume that they're not going to immunize. We do have some newer, different families moving in from Bolivia and places like that, where their children may be fully immunized when they arrive to us, which is quite different, because usually they do not immunize unless they get older, and we really promote the tetanus vaccine because they're working on the grounds and stuff like that. So we can promote that one, but as far as prevention, that's probably quite a difficult one. Breast screening is hard to promote amongst them. They're a question, well, why would I want to know if I had something wrong with me? And it's why. So it's taking the time to explain. So I'm like, well, maybe I'd like to go speak to the physician, and she'll explain why you should have this.
Well, and I find too, because they have their own education system in their community, so they go to school from age 7 or 8 until 14 in their own more religious-based school system, so they don't necessarily have the same knowledge of the body and health that some of my other patients have. So I can't take it for granted that they know basic anatomy if I'm trying to explain why they might be having this symptom or that symptom. So I just find visits take longer, and but it's rewarding, however. I mean, it's nice to work with the community in general, so.
And Dr. O'Neill's being very modest. She actually worked in Colchester when I first started the district and then decided to leave us for a little while. And, but while she was gone, she still followed her Mennonite population back in our district. And some of them actually followed her to her other practice. And we're very happy to have her back in our community again. And we're done. Get the wrap-up sign.
So I'm Charlene Thomas from Pictou County Health Authority, and the first thing I want to say is wow. You know, where would you find on a Friday afternoon this late in the day with March break starting, the chairs are all still full, so how wonderful is that? And you know, as I was listening to the conversations today, I thought really the whole day could be called Where Strategy Meets Community. Because one of the wonderful things about our province and our district funders and organizers is that they give us the garden or the parameters of the garden in which to grow, but they allow us to plant the flowers as we need to plant them within our communities. And how good is that? I mean, that's something to celebrate right there. So I wanted to mention some of the folks that are out in the audience because any of this work we know doesn't come from one person, it comes from a whole multitude of people. So I want to just point out Martin Fisher and Nancy McConnell-Maxner, who are part of our team in Pictou County. And also Philippa Pictou from one of our communities that couldn't be here today, and Juliana, this is the second time her name has come up, who you'll hear about in one of our projects. And when we were talking about what we wanted to do today, we thought maybe we would start with, rather than telling you the things that we are doing, tell you a little bit about how we're doing them, because I think that's at the core of why we're having some success. And I thought I'd start with a couple of personal examples. And I'm part of a biracial marriage, and I'll tell you that a zillion years ago when my husband and I first got together, things were a little different, sometimes exactly the same, but things were a little different. And one of the things that, you know, I thought, my belief was, my philosophy was, people are people, there's good people and there's bad people, and if everybody just treats everybody well, everybody will just get along. That's what I truly believed. I still do, sort of, but that's what I truly believed. And when we started talking about getting married, you know, my husband comes from a very prominent family in the black community, and you know, his grandfather was on a first name basis with one of the prime ministers, and he has doctors and lawyers and all kinds of political involvement, and you know, very, very prominent. And I'm a coal miner's daughter from Cape Breton, but I'm not going to sing. I promise. I'm not going to sing. I'll get Verna to sing. I'm not going to sing. So in terms of our socioeconomic status, there was quite a difference in our status. And when we started talking about getting married, there was a lot of conversation about, I wonder would my family and my community welcome my husband into the community. It never crossed my mind for a second, I wonder would his family and his community welcome me into his community. And it wasn't until, you know, the little distance and that I thought, wow, there was a bias right there. There was a privilege right there, that my lens was just the assumption that, you know, that was a non-issue. Of course they did, thank heavens, but of course they, you know, accept me. But it started me thinking about, you know, there are differences, and we have to start paying attention to that diversity. And so in our county, one of the things that we do, rather than saying, you know, will this be something we're developing that should have a diversity lens to it, we start out with saying it will have a diversity lens to it. And that's one of our first key steps. And we've given ourselves permission, our senior leadership team have challenged us, and we've given ourselves permission to ask that question every time. You know, whether the diversity is race or color or age or gender or religion or socioeconomic status, all the things we heard about today, ask ourselves the question. Because the reality is we're predominantly mainstream, right, Caucasian women of a young age. Don't laugh, okay? And so we need to be aware that that is the lens that we're bringing to our discussion. So we need to challenge ourselves every time. When I worked with a group one time, and we were doing this wonderful project about helping young mums look at childcare, early childcare. And we had a whole section on hair care, right? What products you could use and how you could do children's hair and curling and all that stuff, right? The audience that we were developing this for, the young mothers we were developing this for, were primarily African Nova Scotia. It didn't work. It didn't work. The brushing didn't work. The hair products didn't work. The whole thing that we did with good intention, right? Good intention, we know what that means. It was of no value because we were coming at it from our lens. So that's a kind of a personal and a professional example of how asking that question over and over, what lens are you bringing to the table, is so important. The prayer that I heard this morning helped me fight my greatest enemy, myself. I loved it. I thought it was wonderful. And I think that's part of our task, right? That we have to be really careful that we don't have that one way of looking at something and recognizing that things have to be much, much broader. So we have a whole awareness phase, and because we're constantly checking and double checking and kind of nicely calling each other on what is the lens that we're using, it leads us into the engagement phase that we call principles, partnerships, and processes. And that's where we form our relationships with our communities. That's where we develop the trust. That's where we develop the respect. And if we're doing that really well, if we get off track with something, what happens is it becomes a wave. It doesn't become the ocean. It just becomes a little wave that we have to talk through and work through. The result of that, the result of the kind of engagement we're having with our community that I'm going to give you some examples of, is the outcome is a responsive and inclusive health care for our citizens in Pictou County. Now, how good is that? I mean, responsive and inclusive. We can't do it any better than that. So we're pretty darn good. So just keep that in mind. So some of the things that we've done, we set up a nurse exchange program. We know that emergency rooms are not always welcoming places, particularly for people from First Nations communities, but others as well. And so we wanted to start to do something about that, to change that lens that we were using, as I mentioned. So we established a 2-year nurse exchange in our First Nations community in Pictou County, and the nurse was actually an emergency room nurse. So what happened, the outcomes were, and some of the things we hoped were, we would have a better understanding of navigating the First Nations healthcare system, which is really, I don't have to tell many of you here, but it's not easy to do. And the community would have a better sense of navigating the district health authority system, which was one of the things they told us in our community discussions, that how do you actually ever get services. And so we've just finished our 2-year, and we now have advertised and hired a second person for a second 2-year. The first person has come back to the emergency department, so there's already community relationships, right? There's already a trust that's been built, and we had about 17 nurses in our health authority interested in taking the next 2-year exchange in the community. So how wonderful is that? So it's opened all kinds of doors. Another thing that we're very excited about, and as far as we know, we're the only community doing this, but I might be wrong on it, or the only health authority. We'll take the credit anyway, though. We've started working with our First Nations community, and we know that across Canada and Nova Scotia, the whole identity of mental health and addiction needs and support in the community are very strong. We also know that there's a very high no-show rate in the formal mainstream system, and people, as a rule, don't engage. So, we knew that coming in, and the community reaffirmed that. So we worked with the community to develop a benefits document, not a proposal, because we felt we didn't want that title of proposal or project. A benefits document that helped our funders in primary health care, helped our funders in primary health care support us in actually hiring a mental health clinician who is working in 2 First Nations community, one in Pictou County, one in Antigonish County, and 2 health authorities. And so they report day-to-day on a day-to-day basis in the community, but they're linked to the formal system. So we're going to be able to track the no-show rate for the first time ever, track the kinds of mental health problems, and be there when the person needs us, or the family or the community needs us to be there, rather than on an appointment kind of schedule that we know doesn't work. So we're pretty proud of that one. Community conversations, we've received funding through primary health care and mental health in the province, and we've identified 3 groups: newcomers, First Nations, and African Canadian community. And we want to look at what are the barriers to palliative care services. We have a wonderful palliative care team and program, and as a rule, those communities don't access it. We've also linked with Dalhousie University and are going to be doing some research on that. And what we found out is that there's some research from the Black community around palliative care and how they see that whole transition, that time in their life. There's very little or almost none in terms of newcomers. So we have contacts in all of those communities, and we're getting rolling on our community conversations. The second component of that is that we've targeted our emergency room staff to have diversity and cultural safety and awareness training, and we've completed about 80% of that training with our staff. Responsive behavior. In 2007, we recognized that we had a lot of seniors who were coming from community homes, nursing homes, continuing care kind of operations, and coming to our emergency department, not because of physical health issues, but because of behavioral support needs. And in terms of quality of life for that person, it was not a good situation. And in terms of access and flow in the emergency department, it was not a good situation. So we've partnered with mental health, acute care, continuing care, and our community homes, and we've developed a responsive behavior team who, if there's someone in the nursing home that has a behavioral support need, we will go to the nursing home, work with the team, and hopefully keep the person from going to hospital or needing to go to the emergency department. Lines up nicely with the provincial PESIS model. There's also a training program that we do, and the training is free, so we have nursing home staff coming, and at the end of the day, we have acute care staff and nursing home staff developing a common language on how to support the person around their behavioral needs. We used to have an average of 11 people a month who would come in the emergency department, and often homes would say this person cannot come back. That's the degree of distress and safety concerns that were there. We're now averaging about 2 a month, with the homes identifying the key change has been because of our responsive behavior team. How am I doing? I'll talk fast. We are the health authority that's involved in the Mi'kmaq, Nova Scotia tripartite health working group that is looking at what are the best practices if you want to establish relationships between the culture of health authorities and the culture of First Nations communities. What are the lessons learned? And we've looked at all the literature and all of the formal and informal projects that have happened in Nova Scotia. And we trialed, we got feedback from 2 health authorities and 2 communities, and we're now going to Bear River in the near future and Southwest Health Authority, and we're going to be actually developing a toolkit. So if any of you are starting on the journey of working with the community, here's what our experience has told us will help you kind of get there. We had a special project with our African community, African Nova Scotian community, and looking at gambling within the African community in our area, and received some really good feedback about what was working and what wasn't working, and used that in our community health board planning and our community planning to set priorities for our district. And I'm going to skip some. Okay. So you can see that we have tentacles in a lot of areas. We're so proud of how we're kind of checking and monitoring ourselves. Some of the do's and don'ts begin with the understanding of our mainstream lens. That is the lens that we're probably, with good intention, bringing to our discussions. Ensure that there's continuous self-evaluation. Recognize that sometimes we tend to be a little linear in our, we sort of set our committee, set our goals, set our project, put it out there, and then, and other cultures don't necessarily work in that linear kind of way, so really recognize that. I will leave you with 2 little stories, since I started with 2 stories. One of them was just to let you know that there's still a lot of work to do. My husband and I recently went to, had a little celebration in the Halifax area, and went to a really nice restaurant, and while we were sitting there was a gentleman at the next table who was obviously becoming a little anxious, and a lot anxious. And so he turned his back to our table, and then under his breath, and then not so much under his breath, he said something like, I thought if I came to eat here, I wouldn't have to sit next to with an N-word, right? And so even at this stage in my life, when our life has been very blessed, but even at this stage, you know what my first response was to my husband? I bet you he has an emotional health problem. And my husband looked at me and said, yes, it's called racism, right? So I made, I couldn't, even with all I know, it was hard to, what was I just hearing what I thought I was hearing. The other thing is in our First Nations community and our community from GASHA, we were doing this project for our mental health nurse in the community. And so being a good linear mainstream person, we did our research. I did my research, came up with what the principles might be, had a few drafts ready, came into the community, and had to be reminded that maybe it felt like I was layering on what the model should be, instead of I thought I was going to get this nice little pat on the back, because look at all the homework that she's done. So they kind of had to remind me that we spent a lot of weeks just talking And I'm there with my little plan saying, have a look at this, right? And plus the team members kept changing. We had our committee, but they kept changing. So I learned a whole lot about not going in with that linear way of thinking. Anyway, we're doing exciting things in Pictou County. It's been a blessing to be here today. The energy and the grassroots way that people are moving, I feel very blessed. And have a nice March break, and thank you.
Hello, everyone. I'm Sheila Sears, and I'm really honored to be here on behalf of GASHA to present some of the highlights from our health equity work in our district. All of these initiatives that I'm going to talk about are in various stages of development, completion, reassessment, and there's lots of ongoing work. And those, the 4 things that I'm going to highlight are, I'm going to show you a health equity video that we've just released in late 2012. I'm going to talk a little bit about the how our committee in GASHA has morphed into a health equity and social justice committee. We're going to talk a little bit about some work we've done with our First Nations communities, Budladek and Batangik, and the memorandum of understanding that we have with those 2 communities. And I'm going to read an email from Juliana. She's not here. I'm not checking my BlackBerry later. And then we're going to talk a little bit about a parish nursing model that we introduced in the 3 Black communities of Guysborough County, and Mary's going to speak to that. So first of all, I'd like to show you our health equity video. And I'd like to thank Sudbury Public Health Unit for allowing us to adopt their and adapt their video.
Let's talk about health and why some people are healthier than others. Let's start a conversation about health and not talk about healthcare at all. There are pressures on our healthcare system. Long-term care wait times, ER wait times, binge drinking. But solving these problems won't make us healthy. We know about our health problems such as obesity, cancer, injuries, diabetes, heart disease, asthma. The statistics paint the picture. Too many of us are unhealthy. And we know that diet, smoking, stress, and inactivity all contribute to these problems. But do we really know the causes? It's just not that simple. We know that people who live in poverty have poor health. People who have higher incomes enjoy better health. The more money people have, the healthier they are. Everyone is affected. Health improves at every rung up the social and income ladder. So why is this? There are many forces that impact health. At the individual level, we are affected by many things, including the food we eat, our activity levels, our coping skills, housing, our family situation, and access to health care. Our health is affected by the lifestyle decisions we make, the housing and food we can afford, and the social stressors that we face. These things are in turn affected by our level of education, our jobs, the amount of money we earn, and our sense of community. And if we step back one more level, we can see that our choices are influenced by our culture, our economy, and public policies. Okay, let's meet Mary. Mary is at the clinic again. Why? Her asthma is worse because she's smoking again. Why? She can't afford the rent for her apartment, so she's stressed. Why? She lost her job because of the downturn in the local pulp and paper industry. Why can't she get a new job? She doesn't have the education or experience to do anything else. What does Mary need for her health? She needs affordable, healthy food and housing, the ability to make healthy decisions, and coping skills. She needs knowledge about healthy lifestyles and education so she can get a good job. She needs money for housing, food, and clothing, and she needs work benefits and a safe community with friends and family. She also needs a healthy, diverse economy to create job opportunities. The choices we make are shaped by the choices we have. So, let's shift the focus. We're talking about way more than hospitals, smoking, exercise, and diet. We're talking about our schools, our jobs, our friends and family, our employees, our government, the place we call home, our community. Healthcare alone cannot fix our health problems. We are truly at a fork in the road. If we continue where we're headed, we'll need more resources to treat illness and injury. Healthcare costs will continue to rise. It's a dead-end road. It's not sustainable. It's a very expensive Band-Aid. Or we can take another direction, towards community prosperity, well-being, productivity, and health. We can work towards affordable housing, diversity, walkable communities, local food, community engagement, and early childhood development. We can invest in our community. We are Maritimers, known for our innovation and resourcefulness, known for coming up with creative solutions to complex problems. The evidence is all around us, in the news and in our communities. We are working together to build healthier communities. We can rewrite Mary's story. Mary feels great. She has a municipal council committed to diversifying the economy, property standards that promote clean, safe housing, colleges that offer low-cost upgrade classes, a caring employer, and good benefits. Good friends she can turn to. She has supportive community health staff to help her quit smoking and excellent health care providers when she needs them. So what can you and I do? We can improve our community's health because we are our community. So, let's start a conversation about health and not talk about health care at all. And then, let's get moving.
So that's one of the tools that our Health, Equity, and Social Justice Committee is using and our staff are using. We're also going to create a discussion guide. We're just having that published in the next couple of weeks. So I mentioned before, the Health, Equity, and Social Justice Committee is a new, sort of a new beast in GASHA. And they have established three primary action areas, and one of them is to create awareness of health equity amongst our staff, our physicians, and our volunteers. There are many people that don't understand the complexity of health equity, and we need to really start having lots of conversations about that in many different ways, and this video is one way we can introduce that for people and for some of our community partners. One of the other action areas is to look at tools, policies, and other evidence-based resources that we can use in our district health authority and then make a plan for their implementation. So some of that research and work is being done now. We also want to make sure that all the work we do in this area is based on giving quality care. So District Health Authority is really wanting to stress that with our employees. It's about quality care. There are three goals, and they're listed here. And in a nutshell, I talked about sort of an ongoing education and training program for the people that we work with. And we wanted there to be some consistency in their approach around health equity and social justice. We want people to receive the highest possible quality of care, no matter their social position, what condition they come from or come with. And we want to make sure that we monitor and evaluate the quality components of health equity and social justice work that we do. So that's one of our initiatives. The next one I wanted to talk about briefly is we have two First Nations communities. We have Bungek First Nation and the Budladek First Nation in our district. They're both small communities. We had funding from the Aboriginal Health Transition Fund, and from 2007 to 2009, we had a very significant many significant conversations and relationship building activities with those two communities. And in the end, we have an MOU that's signed by the Chief and Council of each community and our CEO that describes how we are going to work together. And why we did this is because you all know that there are significant jurisdictional issues involved in delivery of healthcare services on reserve, and we seemed in the District Health Authority to keep throwing up a lot of excuses and reasons why we were unable to respond when something happens in these two communities, and they don't have the staff or the experienced staff to deal with some of the issues. And a group of us got together one day. It was a home care issue, post-discharge from hospital. And we were just really frustrated. We said, you know what, this has to stop. We have to work better. We have to be more responsive. We have to say, never mind the jurisdictional issues. We have to do what's right. And we did that, and the MOU really looks at establishing a partnership and looks at really improving communications between the District Health Authority and the mostly the health center staff, but not always. How are we going to coordinate our services better so that First Nations people who live in these communities can access our services and programs and that they are appropriate? And we really wanted to have this continue. So we have a planning framework, and annually we review it. We look at what's working well, what could work better, and what do we need to do to improve it. So I'm just going to read you an email from Juliana, which describes from her perspective what is this really doing for her community. So Juliana is the health director of the Buttingag First Nation. So Buttingag entered into an MOU agreement with GASHA approximately 3 years ago. This document is more than just an MOU. It's the foundation of a relationship between our community and our health authority. This MOU is what we like to call a living document between our two parties. By this I mean, although we have a signed-off agreement, we continue to meet yearly to update our progress. Both parties have committed themselves to nothing more than they can deliver. GASHA has a dedicated staff person who arranges meetings between both parties and checks in regularly for our updates. Yearly, senior management and the health director, and at times Buttingag staff, have met to go through what we have accomplished throughout the year. We also go over any of our obstacles that have occurred throughout the year. Together, we're a working group that continues to work towards delivering programs and services for Buttingag community members. Over the past few years, we've managed to have some excellent community-driven programs delivered in Buttingag from GASHA. To name a few, Women's Wellness Clinic, a team, it's a teaching, eating, activity management program for families, early childhood screening, a Hearts in Motion clinic. All have been beneficial to our members, and they've been delivered in Buttingag, and all of the staff who've delivered the programs on reserve were provided with some form of cultural safety training. An area that was not included in the MOU is mental health. That's not because it wasn't a priority, but rather an area where we knew GASHA was unable to provide services in a way that our community would have liked to have seen. However, we did continue this work on this topic yearly and tried to address some of the mental health needs in the community. And I'm very satisfied and pleased to say that we've managed to start a journey towards addressing some of our community's mental health needs with a shared clinical therapist position between Pictou Landing First Nation and Buttingag. It's my belief that this would not have been possible were it not for the basis and trust of this MOU agreement. Our agreement is soon to be renewed, but I'm very optimistic that the next MOU will again be a reflection of our growth, and that's from Juliana, respectfully. So that's after the signing in Buttingag. And I just wanted to offer a couple of tips, I guess, for people who are thinking about entering into this work. We have been very clear with the community on what we're able to offer and the process that people need to follow when they need something from us that's not something traditional. And usually that ask comes from the chief to our CEO, or it could come from the health director to one of the community program directors. It's very specific, and we are never going in there and offering services or telling people what we're going to do. The ask is specific, and we respond to it. We don't impose our programs in any way. Juliana mentioned that cultural safety training happens, and it's critical. We also ask the community, which staff would you prefer to have to come in to deliver these programs and services? There's history in small communities with staff in some communities. So we know that cultural safety training is critical and the right person is critical. The cultural safety training really gives people an insight on the colonization, the historical trauma that First Nations people have experienced, and it changes people forever when they have that training. We've also been able, through the diversity grants, we've been able to offer that training to our emergency room staff and to our obstetrical staff, and that's been very helpful for our acute care work. So the next project I'd like to highlight quickly is what we call our Birth Project, and it's Blacks and rural communities working together for health, and that's the communities of Lincolnville, Sunnyvale, and Upper Big Tracadie in Guysborough County, as I mentioned. So I'm going to ask Mary if she would just talk a little bit about the parish nursing program that we have.
I was not the Mary in that program. Not. I don't smoke. Yeah, I came with the idea. I was working in Spring Hill Corrections. I did life in the prison system. And I retired and I came home to Upper Big Tragedy. And the seniors there were, most of them, 67% of the population were seniors, and they were on a fixed income. And they were spending $50 just to go see a physician. And I'm saying, wow. Now, if they got to do a follow-up, that's another $50 out of this little check that they're getting. And I'm saying, do you just go and do the follow-up? And they were saying, well, sometimes if I have to, and sometimes they weren't going to get their meds. And I'm saying, wow. I said, the services is there, but there's a gap. And so I was saying, well, something's got to be done about this. So I got my wheels churning in my head, and I said, well, we got to do something. Like, you know, the programs are there, but how can the people get to them? And living in a small rural area, transportation was the big problem. So I said, okay. I went to the Community Health Board and I put in a little proposal, and they said, sure, let's look at this. Because I wanted to make GASHA aware that there was a big problem. Plus, I wanted to make the community aware, like, you know, there's services out there that, you know, that we can grab onto. So GASHA said, okay, we'll give you some money too. So away we went. It was a 10-month project. So we went out there into the community, and the first month, Jennifer, it was my supervisor, she's sitting at this table here. I said to Jennifer, I said, you know what? I just touched the tip of the iceberg. This is a bigger problem than I thought it was. I said, we should have just did one community. But I had put my foot in the 2 other communities, and I didn't want to draw it back because I didn't want to look like I deserted them, and you come in here with all these big ideas, and you're like the rest of them now. And I said, uh-oh. I said, Jennifer, I think, well, we'll give them a little of what we can and move on. So we did. We went in there, and I was so surprised. Like, hypertension was a big thing in the is a big thing in the Black community down there. And I went and we did a little workshop, and they had these huge numbers, and they actually thought these were grades. Like, there was like 210 over 180, and they were right proud of that. They were, oh, look, can I get higher? And I was saying, no, like, you got to go to the doctor. And so anyway, I said, oh, we got to get something done here. So we went, and I got a nurse practitioner, and we said, okay, let's do up a little workshop on hypertension. So I said to myself, now, if we go in there with the traditional standard workshop, it's not going to work. So we went in and we modified it, because I said to her, I said, you know, this is not going to work if we use the standardized workshop. I said, because our people in the Black community has been marginalized so much. Like in Lincolnville, they went to a one-room segregated school. And matter of fact, Lincolnville School was the last segregated school to be closed in Nova Scotia in the late 60s. And so I said, most of them don't have a good education in this, and so we got to be very careful how we go in there and educate them. I said, and that is the problem with the healthcare system in our particular area. They're going in and trying to think that they're educating, but they're really not. It's not being successful because they're going in, standardizing it. They've got a number of patients, and they're sitting there We have our community members, and we have university, grade 12, this and that, and they're trying to give them the same program, and it's not working. Our people are embarrassed. They're proud. They're not going to sit there and say, I don't understand it. They're going, yeah, and they're walking out. Their hypertension, their diabetes still remain the same, and it's a big concern. So we went in, and we said, okay. I said to her, I know with agency, numbers is a big factor. We need the statistics. They're not going to give us funding if we don't meet these numbers. I said, the heck with the numbers. I'm not worried about the numbers. We have to make sure that if we get 5 to 10 people and they get the message, that's what I'm worried about. Then we'll do another one. So we had 10 people into the workshop. I made sure that they were all the same age and they were all bingo people. So we got in there and I said to them, I said, all right, they were all the same age and all bingo people. And I said to her, I said, now, I want you to come casual. Pure sweats, don't overdress, come as you are. So she came and we did up the program. And the program was that we did it all based on bingo. Even the evaluation was a bingo card. And it was very successful, and it was all this hands-on. And when we were done, I was so surprised because the evaluation was we gave them little gifts, and we said to them, what's the numbers for hypertension for a diabetic? I got that, bingo, and they were going on, and like we were so surprised with how much information they had got. And so anyway, at the end of the workshop, I'm a parish nurse, but I came out, I went in the bathroom and I came out and I had the gold chain and hat. I sang the blood pressure song in a rap form. And they sit there and they laughed and they laughed. And so this is what I'm saying, we have to think outside of the box, because for them, they really got into it. So then they went out and they told their friends. Well, gee whiz, I want to get in on this. I want to learn about high blood pressure. And there was one lady there, she said to me, she said, I just want to ask you a question about diabetes. I said, we're not talking about diabetes. Well, Mary, I said, we're not talking about diabetes. Because the problem is that when they get into a workshop and you start talking about this and start talking about another topic, then they get all mixed up. So I used to say to them, it's one subject, one topic, this is it. If I'm dressed up in my rap's outfit for blood pressure, that's all we're talking about tonight. So that's how it was. And so there was little things that we did, like I took the women to do mammograms. And I had a motto, if I asked them to do something, I did it too. And we left no women behind. So we had the community kitchen. We went down to the community center and we cooked. And then we had the seniors come out for Seniors Day once a month. And we had spiritual teaching with them. And we also had health tips each month. And so we would partnership with some of the GASHA people, like, we did Hearts and Motions, and we did all kinds of little programs. So the community members became empowered, and one of the big things that they had was a little community a health care file that I made up for them. And on the side, they would write on the side if they had a health care concern, because you don't go to the doctor every day, and some of them would forget what they would, a problem or a concern that came up. And so they would write it on the side, and they would take their little, and I tell them, take that little file to the doctor, and they take their little file to the doctor, and they'd go in, and they'd say, Dr. So-and-so, look, my ear was aching there on such and such a date, and this was wrong, and the parish nurse said, I'm on too many high blood pressure medications. There are new ones out now, and maybe we should start looking at that. And the doctor would say, what? And so anyway, then the doctor started after a while saying, okay, listen, I like this idea. And so they felt really empowered, like, and they felt proud, like, they'd get there and they'd say, oh, can I write this in, Mary? If it's a healthcare problem, you write it in there and you can discuss it with your doctor. Because before they'd go into a doctor's clinic, they'd sit there and they wouldn't say anything. But they started to become empowered, they started to get interested in their own healthcare, and that's what it was all about. It was all about them getting empowered, and for the doctor to see that they were becoming interested in what they were, their own health. And so it was a little success. Me personally, I just wanted to make sure that GASHA knew what was going on in the Black community. And so they were aware and they enjoyed it. So they had a strategy plan for 5 years, and they actually put funding in place for the parish nursing program. Unfortunately, my husband took sick, and I had to withdraw from the program. I still do parish nursing, and I still chug along, doing different stuff, but I couldn't make a full commitment. But I really think that the program is so valuable. It really is, because I think that the seniors in the Black community, especially in our area, really needs that role model. They need that person to be there for them. They need that person to be an advocate for them. And what I always said is that there's the 5 W's. Who, whose, what, and where. Who's doing the training? These people are used to being in, like I said, a segregated schoolroom, and they're marginalized people. And we need to make sure that they do get educated and that they need to know what they're being taught. Like, like I said, like if you chuck them in a room, healthcare teaching, and they're not picking it up. I'm telling you right now, they're not picking it up. They'll say they're getting it, but they're not. So you have to make sure that they are getting it. And who's teaching them? Do they look like me? No. There's not too many role models out there, so they don't understand, and it don't look like me, and are cultural sensitivity. And what are you teaching? These standard lesson plans. Not everyone is teach and learns the same, so on the same level. So you have to make sure that you do think outside of the box. And where are you teaching at? These ivory towers? Come out of the ivory towers and come into the community. Transportation is a big problem. And we have to remember that if you're teaching at home base, in a community center, our members are a lot more comfortable. So that's all I have to say.
Great, thank you so much, folks. On behalf of the the Department of Health and Wellness diversity community, I would like to thank folks deeply, actually, in relation to making such a positive change in the communities in which you live, work, and play. Folks, I think you're in agreement with me that the panel discussions that we've had today have been exceptional, and please join me in a round of applause for all our presenters. Folks, now I'd like to open up the floor for any questions you have for our presenters this afternoon.
I think what you did is awesome with the seniors, and my mom is a senior, and more times than enough I tell her to write down everything you have to ask the doctor, Mom, and get him to explain things to you. She comes back and she says to me, he said this, this, and this. What does that mean? You need people to go into like seniors' homes and senior facilities or whatever and explain things to them so that they understand, because they really don't. And even though I work for health and wellness, I'm not all up on pharmacare, and I can't explain to my mother why she's paying $800 this year for her pharmacare when it was $700 last year. So it's things like that that they need to understand, and if they had someone at their level to explain it to them at the level that they understand it, it would be great. So thumbs up to you. I think it's wonderful.
Thank you, Daryl.
Good afternoon. I just have a comment. I just wanted to extend kudos, Mary, for your innovative approach to delivering care in the community. I thought that was very creative.
Mary, I was just wondering if you'd be willing to sing the blood pressure song for us.
Well, thank you so much, folks.